Well, hello again. Welcome to part two of evidence-informed decision making for low back pain. I'm here in Huntington Beach because my daughter has about a 3.5 hour practice for gymnastics, so I thought I'd finish off the second series of this. Okay, so in the next 25 minutes, we will pick up where we left off on part one by learning how to apply lessons in life from Arnold's muscles, protecting him from attacks. Even at an old age, I do believe that PTs are the most effective advocates for resilience when we lead by example. And I think our clients can be more influenced when we show and guide them, rather than lecturing them, which is really good for clinicians to learn, and students, to becoming more powerful version of themselves. So here we go. Now, it was an interesting story here. About 2 months ago, I was surprised to have one of Tony K's patients, who, by the way, is a retired professional athlete, tell me that he never believed in the concept of core stability. So, quote unquote, he said, because it's a myth. Now, I asked him why, and he stated that he never had any back pain issues just doing his regular exercises, which I can imagine maybe are quite intense compared to most as a retired pro athlete. And this was also interesting for me to hear from a patient because you have a weak core, or that's why your back hurts, or you need to strengthen your core is often a mantra heard in our PT gyms. Lederman in 2010 concluded in a study titled The Myth of Core Stability that weak trunk muscles, weak abdominals, and imbalances between trunk muscles groups are not pathological, just a normal variation. The division of trunk into core and global muscles that system is a reductionist fantasy, which serves only to promote core stability. Weak or dysfunctional abdominal muscles will not lead to back pain. Tensing the trunk muscles is unlikely to provide any protection against back pain or reduce the recurrence of back pain. Core stability exercises are no more effective than and will not prevent injury more than any other form of exercise. Core stability exercises are no better than other forms of exercise in reducing chronic low back pain. Any therapeutic influence is related to exercise effects rather than core stability issues. There may be potential danger for damaging the spine with continuous tensing of the trunk muscles during daily and sports activities. Patients who have been trained to use complex abdominal hollowing and bracing maneuvers should be discouraged from using them. Then Mannion et al. In 2012 concluded in their study that neither baseline lateral abdominal muscle function nor its improvements after a program of stabilization exercises was a statistical predictor of good clinical outcome. I think Greg Lehman in 2012 summarized this concept best, in his blog, quote unquote, in other words, we get results not from the reasons that we think we get results. According to Augard and Carroll in 2019, the claim that core stability exercise is one of the most effective options for low back pain is without merit and clearly lacks supporting evidence. It has been demonstrated thoroughly that in those with low back pain, there is no long-term difference between different exercise modalities, including different modes of core stability. And this is core stability that was described in Michelson et al. In 2016, Saragiotto et al. In 2016, Schinderman and Katzler in 2013, Smith et al. 2014, Vassiljan et al. In 2012, and Wang et al. In 2012. So what's really nice about this is that if my patient is not able to fire super specific muscles of the core, it doesn't matter in the long term. I can just make them strong with good, general, easy to learn exercises. However, patients who are able to do specific core exercises will more likely be able to reduce perceived pain in just the short term. A very recent study by Yaguchi and Yakut in 2019, this year, also found no difference in long-term outcomes with uber-specific scientific scoliosis exercises versus just the general core muscle exercises. If you look at this slide, I know it's going to be a bit silly, but I guess it shows that we can keep our exercises simple and still be very effective. But Confucius say life is really simple, but we insist on making it complicated. So welcome to the world of complexity bias. Question here, which do you think is more effective? The short answer, is going to be the exercise that my patient tells me is the one they like. So however to limit reductionism, we'll go through the longer, more detailed answer. So do you think the exercise on the very top left over here with the guys, squatting with, 225 on his shoulders, doing battle ropes while balancing on a balance board is any more effective than just the squats you see below them, or the guy that you see is doing the handstands with the dumbbells over here is going to be any more effective than maybe just planks or the bird dog you see on the bottom right exercises? No. So Wang in 2012 found that core stability exercises was better than general exercises for the short term for pain relief when the results were combined in a random effects model. However, no significant differences were observed between effects of core stability exercises and general exercises at 6 months or 12 months. And compared to general exercise, core stability exercise resulted in a significant improvement in functional status by random effects model in the short term. But this was only observed for maybe 3 months. So what does this mean to me, and how can I apply this into the clinic? So it tells me that I can begin with specific exercises, prescribe those to my patients to maybe maximize relief for acute low back pain. But then I should introduce activities that my client loves to do, something that will keep them consistently active for maybe the long haul in life. Preferably, I'd like to eventually transition my clients into resistance training for even up to 80% of their 5-rep max, to make them more durable, just like Arnold. This last step, I feel, is the missing ingredient in what we as physiotherapists do, and is one of the reasons why patients sometimes come back 2 months later after we've discharged them with the same diagnosis on a brand new prescription from their referring physician. These findings of Wang's study was such good news to my ears only because on occasion I'll work with somebody with really poor motor control that can't get specific exercises, but that's now okay because I know I can choose many other exercises for my client to be able to do and perform. And even better, maybe it's something that they really love to do. So what truly matters the most is being able to find out what our patients love to do now by just listening to them, asking what their interests are, and then developing a program that they can do religiously. So what now if they can't do DNF to reduce cervicogenic headache? If they want to do squats, let them do squats. Now, if core versus regular exercises don't have a major impact in the long term for functional outcome of back pain, then what exactly does? Not exact thing, but my short answer is that in this complex question would be that our words are the biggie. Instead of using words that you see around the depressed thought virus infected little man sitting on the left side of this infographic or this slide, we should try using the words around the happy man jumping for joy on the right side of this slide. So the more safe words you use and the phrases that you use, the better we start becoming at it. And the more that patients hear it, the more that they'll be able to get really good at pointing out the positive findings in us human beings. The words and sentences that we wire together end up firing together. Try replacing the words like broken with strong, unstable with adaptable, subluxed with capable, torn with normal, muscle imbalance with balanced, degenerated with resilient, worn out with robust, and weak with healing. So how do we prepare ourselves to teach patients about pain? Let's take this test together by voting true or false, and getting a score of more than 80% suggests that you are qualified to answer your patient's question when they ask you about pain. Now, getting a score below 80% might suggest that you may be telling patients information that is unhealthy. Follow along and sort of just mark the correct answer on this RNPQ test that I emailed to you. So number 1 here, it is possible to have pain and not know about it. True or false? Okay. Tick tock, that would be false. Number 2, when part of your body is injured, special pain receptors convey the pain message to your brain. Okay, true or false? Okay, the correct answer is false. Okay, number 3, pain only occurs when you are injured or at risk of being injured. Here goes. The answer for number 3 is false. When you are injured, special receptors convey the danger message to your spinal cord. Okay, true or false there? Okay. Number 4 is true. Okay, here we go to number 5. Special nerves in your spinal cord convey danger messages to your brain. Okay, what do you think it is? Number 5 is true. Number 6, nerves adapt by increasing the resting level of excitement. Okay, that one is also true. Number 7, chronic pain means that an injury hasn't healed properly. Okay, so number 7 would be false. Number 8 is worse injuries always result in worse pain. Okay. Number 8 would be false. Okay, here's number 9. Descending neurons are always inhibitory. Okay. Number 9 would be false. Number 10 is pain occurs whenever you are injured. Okay. Number 10 is also false. Okay. Number 11, when you injure yourself, the environment that you are in will not affect the amount of pain you experience as long as the injury is exactly the same. Okay. Again, number 11 is also false. Finally, number 12, the brain decides when you will experience pain. That, everyone, is true. All right, so congratulations, everyone. You got 100%. All right? You all got 100%. And together as a team, we are now qualified to answer questions when we educate patients about pain. All right, so just make sure you are telling them this information, which is the most current evidence we know today. In 2019, Darlow et al. States that healthcare professionals have a considerable and enduring influence upon attitudes and beliefs of people with low back pain. It is important that this opportunity is used to positively influence attitudes and beliefs. Cuyol Vasquez et al. In 2019 concluded that verbal suggestion has the potential to induce expectations which may generate hypoalgesia through the placebo effect. Words can either produce pro-inflammatory or anti-inflammatory chemicals within our patient, and it gives hope, and it can also destroy hope. So that's why it's important to get a good score on that test. A fairly new term I was introduced to while researching all this stuff is negative priming effect, which fixates people into an unhealthy belief. The list of words you see on the left promotes nocebo-filled conversations and should be replaced also with phrases seen on the right side to reduce iatrogenic effects in PT. So please refer to this attachment, which I also sent you in my last email. So what other solutions can we look into reducing our back pain epidemic? Research have known for over 2 decades that the 11 terms on this list are the most effective treatments found in the best care plans for musculoskeletal pain. Yet they are rarely included in the majority of maybe treatments and plans I see. So researchers like Peter O'Sullivan believe that adherence to these guidelines would massively reduce the suffering and cost of musculoskeletal pain in our society, especially low back pain. That's why I chose to place it in my toolbox. So he came up with this fantastic test to help clinicians learn how to communicate with their patients in an anti-nocebo way. So according to Godfrey et al. In 2019, systematic reviews have concluded that physical therapists lack the confidence in successfully delivering psychological interventions which might be rectified with additional training and support. They go on to saying, we have demonstrated that ACT or ACT-related skills could be successfully integrated into using physical therapy with additional staff training and support. So meaning to say we can learn how to apply psychologically or psychosocially informed treatments to our already solid understanding of biomechanically informed PT treatments. Again, I'd like to advise everyone to take the test we took together as a group in part 1 of this presentation by Peter O'Sullivan, Dr. Leo Nung, and Peter Edwards. Take this time to click on the link to review this on your own. Now, a summary of the solution written in The Lancet states global gaps between evidence and practice exist, with limited use of recommended first-line treatments and inappropriately high use of imaging, tests, opioid, spinal injections, and surgery. Doing more of the same will not reduce back-related disability or its long-term consequences. The advances with the greatest potential are arguably those that align practice with evidence, reduce the focus on spinal abnormalities, and ensure promotion of activity and function, including work participation. Now that you're aware of more evidence about back pain, it should be easier to gather all this data to make a more balanced decision in developing a patient's plan of care. So let's take a look at the 3 components of evidence-based models, just mostly as a review. So number 1 over here, you see on the bottom right-hand side is best available evidence. So this is primarily scientific. The picture was recently taken from our dry erase board in the office. Insurance companies are slowly beginning to recognize the low value of unattended electrical stimulation and have stopped reimbursing for it. This I feel is a step in the right direction, but is also so extreme that it neglects clinicians' knowledge and patients' wants and needs. On a positive note, it will force us to now treat only with attended e-stim, which will most likely enhance our outcomes. Now you take a look at number 2, which is clinicians' knowledge and skills. This based on clinical experience. Now number 3 is wants and needs. This is driven by our stories our patient has heard from maybe friends or family or even read on the internet. So evidence-based practice requires that we never separate these 3 components. They are always together. Now over here, Dr. David Cherry found in his study, evidence is in support of psychological interventions when patients have had long-standing symptoms, including social trauma. He states that most of his patients are overachievers or athletes and perfectionistic. Those have failed previous therapies and have had a recent major life event, like moving or a divorce or dysfunctional family. His structure program, which is a goal-oriented program, is often a timed activity, so patients can see their improvement from one day to the next. His research has shown that a dedicated interprofessional team combined with psychological, pharmacological, and no narcotics approach has helped his patients, and his research followed his patients for 2 years post-discharge. This is from a lecture handout by Susan Strelka in Pain Management for Children. So why on earth do I still see short and long-term goals written in a way that makes them pain-centered rather than function-centered when I do chart reviews? So we should also be speaking the same language because we all work together as a team. Some of us use percentages when asking patients how much better are we doing. Some ask function, like what is your PSFS on walking your dog, and is it like maybe a 5? Some ask how much pain are you feeling when you're walking your dog. Is it about a 5? So while others still ask, is it a little easier now, or is it moderately easier now to maybe walk your dog for about 5 minutes? And what exactly is the MCID of these other goals? So how do we know they are even met and produced a perceived significant functional improvement in our patients? Where's the evidence to support some of the goals when we write it this way? I've learned that the best way to find out and develop our patients' rehab goals is by using cognitive behavioral therapy approach, such as motivational interviewing. And you can refer to the handout management dispensed during last year's CPM project for more details on MI. In it, I included a great example of how the readiness ruler can be used to increase successes when writing our patients' rehab goals. Okay, now that we know how to develop a functional centered goal and not necessarily a pain centered goal, we can begin to delve into evidence informed exercise prescription. The third and final video of this series will demonstrate progression into deadlifting, overhead pressing, Bulgarian split squats, etc. Combining heavy resistance training with pain neuroscience education to make our patients more durable rather than weaker is, in my opinion, the best solution to calming our worldwide back pain epidemic. Dr. Yatendra Kumar Yadav in 2019 wrote a blog with this infographic quoting Thomas Edison. The doctor of the future will give no medicine, but will interest his patient in the care of the human frame, in diet and in cause and prevention of disease. Thank you. Keep your eyes peeled for this infographic on your desk or email. Look it over, and it will prepare you for my next presentation with our very own special guest, Mike Leal, who has literally evidence coursing through his veins. So please email me or call my extension if you have any questions. Again, I thank you for your time, and stay tuned for the third and final series.